balloon pump checkoff. So there are two goals of balloon pump therapy. The first is to increase your coronary perfusion. Normally when your heart beats, some of the blood that it ejects gets returned into the coronary arteries to perfuse the heart. But when your heart's in cardiogenic shock and your cardiac output drops, obviously you don't get good blood flow to the heart. The balloon pump, when it inflates, actually pushes blood into the coronary arteries to help reperfuse the heart. So the better blood flow you can have, the more oxygen you can deliver, hopefully your heart will work a little bit more efficiently, heal a little bit better. So that's the first goal. The second goal is to decrease your left ventricular afterload. When the balloon pump deflates, helium is pulled out of the balloon pump. It's an active deflation, not passive. The active deflation creates a sort of vacuum and actually helps suck blood or pull blood away from the left ventricle, which decreases the workload of the heart. So two goals: increase coronary perfusion, give the heart more blood to work with, more oxygen to work with, and then the second is on deflation, pull blood away from the left ventricle to decrease your afterload. We're going to skip through these because there's another video you'll watch with that. All right, safety checks. So the first, when you get a balloon pump, either you admit it or you start your shift, these are the things you want to go through. I personally like to do my safety checks from my patient and work my way to my machine. So when you are starting with your patient, you want to make sure you check your insertion site, and this is your device safety check. So you want to look at your insertion site, do a normal insertion site assessment, check your tubing, make sure that everythim's plugged in where it should be, that all your stopcocks are turned the right way, there's not a lot of tension on your line, it's secured in a good place. Make sure if you need a knee immobilizer, you go ahead and order that. And then make sure everything is plugged properly into the back of your machine. As you go along your tubing, there's a clear tubing. This is your helium. You want to make sure that's completely clear. If there's anything in there, you definitely need to notify your team, especially if there are red pepper flakes. That's considered a medical emergency. That means blood from your aorta has gotten into that helium tubing, which is a very serious situation. So you make sure those are clear. And then you want to go through, on your balloon pump, you want to take a look at all of the program settings. Just like if you had an LVAD, you would make sure your RPMs were set at what you were told in report, or if you had ECMO, same thing. The same concept applies to your balloon pump. Make sure your trigger is set to what you were told in report, and if it's not, go over why or fix it. Your timing's 1-to-1, you're an automatic, all that kind of stuff. Or if you're using different settings, make sure you know why. The very last thing, when you go to do your assessment of your patient, everybody's pretty good to assess the insertion, whatever extremity's cannulated, people are really good to check that pulse, but you always and forever, amen, need to check your left radial pulse. No matter which way your balloon pump is placed, if it's femoral or if it's axillary, it can migrate and include the left arm, the artery that perfuses your left arm. So you definitely need to be checking your left radial pulse. So now every hour after that, these are the things you want to be doing. You don't need to chart on it, just keep an eye on your insertion site. You're probably on anticoagulation, and it's usually in the fen. It's a pretty dirty place. If your cardiogenic shock patient gets septic, that's usually bad news bears. So make sure you're keeping an eye on that, keeping that clean. Your helium tubing is an hourly check, just like your ECMO cannulas are an hourly check for clots and stuff. You want to make sure that's completely clear. You need to print your strips every single hour. Those numbers get translated into SCM. You need to post them every 4, and I'll go over what that looks like in a minute, but you need to print them every single hour and put those into SCM every hour. Then you need to be checking and charting your left upper or your left radial pulse, and then whatever extremity is cannulated, you need to check that pulse as well. Make sure both of those go in your chart every single hour. And then your urine output. No such thing as Q2 urine output on a balloon pump, because if it migrates south, you're going to include your renal arteries, and you don't want to be waiting a couple hours before you catch that. You need to make sure you get an hourly urine output every time. All right, so this is what our charting looks like. This is what your strip should look like. All of these numbers translate really easily into SCM, with the exception of your mean pressures. So you're going to get one mean pressure on your strip, but SCM actually asks for two. It asks for an unassisted and an assisted. Don't worry about it. We're not going to change it. Epic is coming. So just, it's a calculation of both that the balloon pump does for you. If you want to go ahead and do your own manual mean pressures, good for you, but you don't have to. Just go ahead and put that pressure that you get from your strip into the assisted mean spot. On your initial assessment, you want to chart everything you possibly can. You should have two parameters, one for the actual balloon pump numbers and everything, and then the second is for your insertion site assessment. So you want to tell them, what kind of, or at 8 or 2000, you want to make sure you tell them what kind of pump you've got, where it's cannulated, all the settings, numbers, and then what your dressing looks like. Every hour after that, you just chart this little section here, which is what your settings are, what your numbers are. And then down here, every 4 hours, you'll just chart your insertion site assessment like you normally would. This is what posting a strip looks like. So we used to be super anal retentive and like fold the strip really pretty. You don't do that. It doesn't actually get charted that way because it won't go through the scanner properly. You are legally liable to post a strip every 4 hours. You have to do it. So they need to be cut and they need to be taped on your paper. This paper is at the clerk's desk, and if they don't have any, they can print them off for you. You want to put your patient's label up here, cut your strip in half, and just tape it with clear tape. You can get that at the clerk's desk as well. Tape it. Just get 1 sheet per shift. That's a personal preference because I think that's just cleaner. But you can put 3. You can actually fit 4 on here, but it's just cleaner to do 3, but do whatever you want. But sign it, date it, tape it, chart it. All right, nursing interventions. Couple things you need to know for any given shift. First, you want to make sure you put your balloon pump in standby for your chest x-ray. If you get the chance to see the model balloon pump when it inflates and deflates, it moves a lot more than you think it would. Putting it in standby for the chest x-ray confirms placement, and it's the most accurate way to check your balloon pump's placement. So x-ray will come in, put the board under, and then right before they click their button, you put it in standby, run 6 feet away, and when they take their picture, you come back and you hit start. Nobody should die in that time just because you put your balloon pump in standby for a few seconds. So make sure you do that for them so you get a good placement. The other thing is you can put it in standby to do a couple spot checks on an echo. Just offer to the person doing the echo, let me know when, if it's a good time for you. I can put it in standby for a little while. That helps them get really good pictures as well. Second, we need to titrate our drips to the pressure on the pump, not the pressure on the monitor. This is kind of a big point of contention between us and cardiology, but the AIC guidelines recommend, this is the people that wrote the protocols for the pump, you need to do it from the pump itself. And if you want to know why, I'm more than happy to go into it, just let me know. But if you ever have to argue that, the link is on SharePoint. You just go to our SharePoint, type in IABP, there's a folder, and in the folder it'll say AAC guidelines. Do what you can to advocate for your patient, still up to physician preference, so if you need to, just chart it, make sure you cover yourself and put in the quick notes that you've advocated the best you can. Trigger is typically EKG in automatic mode. That's kind of the default. If for any reason your balloon pump loses its EKG, let's say you unplug your leads to do your bath or your patient codes, it should default to pressure trigger. That means it's going to read your ART line instead of your EKG. This should happen during a code, but make sure if your patient is coding, use the primary nurse, delegate to somebody else, another nurse, hey, will you manage my balloon pump? And then that person will just make sure it's in pressure and it stays on through the whole thing. After, if you get ROSC, make sure you get a chest x-ray. If you don't get ROSC, make sure you turn it off. And then trend your urine output again every hour to make sure that your balloon pump hasn't migrated. If you have any hematuria, acute change in urine output, even if it's 1 hour, you need to make sure you communicate it. Probably get an x-ray. It's a super easy way to just double check and rule out that your balloon pump's migrated. Okay? All right.